Assalamu alaikum students. Today we are going to learn something about hemolytic anemia and what is it, why is it considered a disease, what should we know about it. So let's start. Hemolytic anemia is a decrease in number of RBCs due to damage or loss of the red cells inside or outside the blood vessels. It may happen inside or outside the cells too. Inside the cells like mononuclear phagocytes, inside the blood vessels like in hemolytic anemias, and well, inside the cell like phagocytes, it will be considered outside the blood vessels, and like senescent cells or damaged cells, problems in their hemoglobin, cell membrane. So such cells, phagocytes, are abundant in spleen, also in liver and bone marrow. Now here we have got a differential diagnosis of anemia list, which you can look upon and have an idea that there can be a lot of causes. Of course, no list would be absolutely exhaustive, but important points or important reasons would be mentioned in most, like this one. The one most important point is in the anemia is that is if the red cells are destroyed prematurely, that is before their lifetime is over of like 120 days, 110 days, or maybe 130 days, sort of. Okay, if they are destroyed earlier, the speed of destruction may be so much that it would be less than the speed of replacement. Then there will be anemia. And another problem, that extravascular hemolysis within the mononuclear phagocytes causes or leads to a hyperplasia of phagocytes, which increases the destruction of already damaged or weaker RBCs and aggravates the anemia. The third thing, it also causes splenomegaly. That is, hyperplasia phagocytes also causes splenomegaly. So more and more phagocytes can be fitted in, and the anemia keeps on aggravating. Okay, now this phagocytic engulfment takes place when there is usually when there is damage to the cell membrane, or the red cell is less deformable due to precipitated hemoglobin, some problem in the cell membrane, or decreased elasticity of the cell, well, due to the membrane. Okay, so hemolytic anemia, a few symptoms. Okay, you can have jaundice, increased, bigger spleen, triad of hemolytic anemia, jaundice, splenomegaly, paler. Person will be pale. You can clinically easily look at them and see that they are pale. Jaundice will occur when there's too much anemia, too much hemoglobin, all that thing, metabolic process leading to increased bilirubin, unconjugated hyperbilirubinemia. It goes out of the capacity of the liver to metabolize all of the hemoglobin. So there are symptoms. Extreme changes in shapes are required within the RBCs to be damaged or eaten up by the macrophages. When they cannot do so, extreme changes will be required to navigate the splenic sinusoids. When they cannot, their red cell members are less elastic or irregular, they will be eaten up by the cells in the spleen. So, features, as you already saw: jaundice, splenomegaly, anemia in any kind of anemia. Intravascular or extravascular destruction of red cells. You can see in this diagram a few conditions. Again, now increased red cell destruction, hemolysis. We have got some few reasons in this list: increased genetic defects, okay, enzyme deficiencies, different types of enzymes, or acquired genetic defects, okay, defects in the cell membrane or in the hemoglobin or in the enzymes. Basically, these three are the main culprits. Well, again, they've got many reasons. Hemolytic anemia, non-immune immune. So there is immune hemolytic anemia due to immunological reasons. Well, the red cells are marked by complement or the antibodies, or even by some foreign molecules known as heptans. Now, the immune system would regard them as foreign antigens. And of course, if there is complement or antibody attached, that means that they attach to a foreign antigen, and they help in phagocytosis. So cells come and take up the RBCs in an attempt to remove foreign antigen which might cause harm. Extracorpuscular, extracellular, intracellular reasons. Okay, so it can be thalassemia major, cirrhosis, infection, burns, so many things, copper poisoning, and autoimmune, alloimmune, immune related, warm and cold, autoimmune hemolytic anemia. It can be a mixed picture too, sometimes alloimmune, that is the same species from human beings, transfusion reactions or APO incompatibility. Heptoglobin, alpha-2-globulin, is a protein present inside the uh, blood or serum, which will attach hemoglobin, okay, and the free hemoglobin can then be easily excreted in the urine. But the thing is that this system, intravascular hemolysis, heptoglobin can be overwhelmed quite easily when there's too much free hemoglobin. It has a certain capacity. When that is reached, we will find free hemoglobin within the blood, and when that goes to the kidneys, it damages the kidneys. It gets stuck in the glomerular units, glomerulus, and it can actually damage it enough that it is unusable in the future. So the capacity of the kidneys is affected, and in extreme cases it can cause an acute renal failure or chronic renal failure over time. Intravascular hemolysis can happen due to mechanical injuries, as we already mentioned, complement fixation, antibodies to parasites, intracellular parasites like malaria and other toxic factors, poisoning due to metals, drugs causing formation of heptans, as just mentioned. Mechanical injury directly happens due to prosthetic cardiac valves, artificial valves, narrowing of the microcirculation due to thrombosis, due to fibrosis later on, irregular areas then inside the lumen. Physical trauma, repetitive physical trauma, they say marathon running or while running or jogging with improper shoes, that gives jerks. We see that physical trauma can be had through too much running or having improper shoes. Nipping of the red cells, damage, attempted eating up our macrophages. Bone marrow smear in hemolytic anemia, normoblasts. This is what the bone marrow looks like, increased number of erythroid progenitors. Toxic injury can happen by clostridial substance which results in release of enzymes that digest the red cell membrane. So direct injury, toxic injury to the RBCs is seen. Intravascular hemolysis, as you already seen, it will cause anemia, hemoglobinemia, hemoglobinuria, hemoglobin in the blood and in urine, hemosideruria, jaundice. Blood vessels, hemolysis, reticular endothelial system. Now, hemolysis, intravascular or extravascular, you can see what will happen. Intravascular can lead to renal failure, and it leads to so many other symptoms: abdominal pain, esophageal spasms, dysphagia, difficulty in swallowing, dark colored urine, hypertension, thrombosis, and the resultant complications therein: thrombosis, hypertension, pulmonary and systemic, platelet activation and thrombosis, erectile dysfunction. And extravascular because it's in the cells, splenomegaly, unconjugated hyperbilirubinemia, urobilinogen is increased. So, a bit about clinical symptoms. Free hemoglobin, heptoglobin we already discussed, and free hemoglobin oxidizes to methemoglobin, brown in color, if heptoglobin is depleted. Renal proximal tubular cells reabsorb and catabolize much of the filtered hemoglobin and methemoglobin, but again some passes out in the urine imparting a red-brown color. And again, if it starts getting stuck in the glomerulus, it can cause that glomerulus to be damaged enough so that the nephron cannot be used for filtration anymore. Features: premature destruction of red cells, elevated erythropoietin levels to compensate, increase production of red cells, new red cells, degradation products accumulate. RBCs, there will be more, but hemoglobin degradation products are important because they can cause a lot of symptoms and renal damage. Reference range: red cells normal, again warm and cold hemolytic anemias. So IgG in warm and IgM in cold. Okay. Temperatures warm because it is seen active at body temperature, and cold is not seen active at body temperature. Recorded cold hemolytic anemia because it is seen at 5, 6, 7 or 8 degrees below the normal body temperature. That is, it will be seen in the digits, fingers, hands, feet, and it has been observed 4 degrees centigrade. It's quite active. That's why. And antibodies, anti-RH warm. Okay. Similar symptoms and other things which we've already discussed. So hemolytic anemia, our general considerations now become to one specific disease, hereditary spherocytosis. This inherited disorder is caused by intrinsic defects in the RBC membrane. So RBCs, spheroid, spherical, less elastic membrane, less surface area, less deformable. So they are damaged or eaten up by the phagocytes in the spleen mainly, and hence anemia. So sequestration in the spleen leads to anemia. Autosomal dominant inheritance, 75% of cases of HS. Either it's mixed. Picture microscopic of the cell membrane of the red blood cell from the normal to abnormal. What happens that small parts of the RBCs may be broken down because of weaker cell membrane, surface area decreases, they become more spherical instead of biconcave disc-like. Severe form of disease that is usually caused by inheritance of two different defects. Compound heterozygosity, as we just mentioned, 75% is dominant, rest is rather a mixed form. Pathogenesis, diverse mutations that lead to an insufficient or compromised structural integrity of membrane. So not just one problem. Lifespan comes down, average 10 to 20 days instead of the normal 120 days. So much less. Mutations most commonly affect hankarin, band 3 protein, spectrin, or band 4.2. All of these form structural components of the RBC cell membrane and the supporting structure of fibers and globular proteins below the membrane inside the cell, which give it strength and flexibility. So loss of integrity leads to the loss of cell membrane, less surface area. So spherical shape comes on, and spleen has a major role in the destruction due to the phagocytes present in it. Now, microscopically, they look like this: normal RBCs and hereditary spherocytosis, HSRBCs. Loss of central pallor because they are no more biconcave, okay, and sometimes irregular shapes. The difference in size increases in the HS of the RBCs, that is. Spleen enlarges in such patients and even more destruction of RBCs is seen. So splenectomy is the treatment actually. It increases the lifespan of RBCs and it almost, well, not cures the disease, but almost cures the clinical symptoms. Although there is a downside to this treatment, of course, always there is adverse effect. Infection due to encapsulated organisms is seen more in such patients, so care has to be taken, such as pneumococcus, okay, or Neisseria meningitidis. Such infections can increase. Morphologically, cells are smaller, quite smaller, dark staining, lacking central zone of pallor. Some autoimmune processes also produce phagocytosis because they are partially damaged by the phagocytes. They lose the surface area of the cell membrane and become spherocytes. Other clinical features: reticulocytosis, hyperplasia, hemosiderosis, jaundice, mild. Cholelithiasis is seen in 40 to 50% of adults too, although it is common otherwise too, cholelithiasis. Mostly doesn't get symptoms right away. Splenic enlargement. Some hemolytic anemias, spleen may be enlarged, but it is not enlarged as much as in hereditary spherocytosis. Anemia, splenomegaly, jaundice, like we already discussed, and in compound heterozygotes, smaller number of cases, the anemia is present at birth. Jaundice, of course, requires transfusions. Sometimes in some people of this mixed origin, it is quite mild or asymptomatic. And the reason is that increased RBC production can match the RBC loss because there is less loss, so the production can keep up by increasing itself. Complications: aplastic crisis, parvovirus infection, viral infection. Suddenly, it causes decreased or almost stopped production of cells in the bone marrow. The virus infection kills red cell progenitors, so production ceases until an effective immune response commences, which takes 1 to 2 weeks, and the patient is in really trouble due to this. Hemolytic crisis is also seen, which is like a plastic crisis but less severe. But transfusions may be required, will be required. That was about hereditary spherocytosis. Now we come to glucose 6-phosphate dehydrogenase or G6PD deficiency anemia. Enzyme deficiency. This is not membrane problem, this is an enzymatic problem. Hemolytic anemia again. Now the RBCs are vulnerable to oxidation injuries. Abnormalities in HMP shunt or glutathione metabolism. Glutathione is a defensive mechanism against oxidation injury. Decreased or impaired enzyme function. This is a pictorial presentation. This is what we might see in G6PD deficiency. You see helmet cells or sometimes target cells, irregular cells nipped upon by the cells phagocytes in the spleen. And in the smaller window you can see aggregated hemoglobin also. G6PD reduces NADH to NADPH, okay, oxidizes glucose 6-phosphate. Now this NADPH provides reducing equivalents which convert oxidized glutathione to reduced glutathione. So then it can again oxidize itself and prevent the damaging effect of oxidized radicals, oxidation radicals within the cell produced due to metabolism or whatever activity, UV damage. So oxidant injury is catalyzed. H2O2 is also utilized in this metabolic activity. X-linked trait, recessive X-linked trait. It's a recessive trait. Uh, in areas where this G6PD deficiency is found, more actually, they see that it is because of a protective effect against Plasmodium falciparum malaria. In Africa, there's a lot of Plasmodium falciparum malaria, and this disease is seen more so in Africa actually. Pathogenesis, misfolding of the enzyme protein makes it susceptible to proteolytic degradation because the molecules always have a life. When it is seen that they have been damaged, actually they were not damaged, but they were not produced properly. So other enzymes responsible for catalyzing them, they just come and break them up. So their life is less. Enzyme molecules are less available. So less reduced glutathione is made, and less chances of defense against oxidative injury. Infections which increase metabolism or oxidative damage, this can be seen. Activated leukocytes, hemolysis, viral hepatitis, pneumonia, typhoid fever, all of these infections can do. Any serious infection can do this. Drugs and food, too much food also increases oxidative stress on the cells, especially deep fried food. Antimalarials might do it. Beans, Java beans have been known to precipitate the problem. Uncommonly, this may present clinically as neonatal jaundice. It doesn't do that usually unless some precipitating factor is there. And a chronic low-grade hemolytic anemia has also been seen. Some environmental triggers, everything is not known. It will cause intravascular and extravascular hemolysis. Cross-linking of reactive sulfhydryl groups on globin chains. That is what happens when there is a G6PD deficiency. These globin chains become denatured. They precipitate, as you saw in the diagram, within the cell, causing Heinz bodies, and this is attacked upon by the phagocytes to pluck out these Heinz bodies. They are perceived as abnormal, and hence damaged RBCs are produced, which will ultimately phagocytose totally. Symptoms: jaundice, fatigue, anemia, pale, rapid heart rate, shortness of breath, enlarged spleen. Heinz bodies damage the membrane sufficiently to cause intravascular hemolysis, as we've already discussed. So, Mediterranean variant, there is a Mediterranean variant. Hemolysis tends to be greater in individual. It is an unstable form of the disease. Since older red cells are at a risk for lysis, episode is self-limited. Younger cells can deal it better, but in older cells, all of those capacities are exhausted. More hemolysis ceases when only younger G6PD replete red cells remain. Recovery phase, reticulocytosis. That means a lot of new red cells are being formed. And episodic form of hemolytic anemia is seen. It is only intermittent. Okay. So features like splenomegaly or cholelithiasis are absent. Another Rh incompatibility, another reason for hemolytic anemia, often seen in younger patients, rather newborns. It is a red blood cell surface antigen. First of all, discovered in monkeys. That's why known as rhesus factor. Rhesus disease, rhesus negative blood, rhesus positive blood, plus and minus. You see, positive and negative. And when the mother is rhesus negative and the pregnancy is with a child who is rhesus positive, then problem arises, which may occur during abortion, due to trauma, invasive obstetric procedures, or normal delivery. A bit of blood is going to go from the fetus into the mother. Mother is negative and father is positive, then this problem can occur. But not so in the first child, because the cells, RBCs leaked, and the first child will be taken as foreign, and then antibodies formed, and next child there will be problem and much more problem in the subsequent children. So anti-D injections are given, okay, to control this problem against the antibodies. Must produce maternal Rh immunoglobulin G, IgG, persists for life, can cross from placenta to the fetus circulation. So most of it can cause death, which was known as hydros fetalis, death of the fetus. Antigen antibody complexes and fetal erythrocytes are eventually destroyed. Rh blood groups have many subtypes. D antigen is the most immunogenic. They say that D, C, small e, many. There are other sort of 30 types of antigens on the RBCs, but ABO group is the most important, and then D subgroup in the rhesus antigen is most important. Most commonly, this causes incompatibility. 90% sensitization occurs during delivery. So first born child is not affected, and women prone to Rh incompatibility, the second child would have a mild anemia. Okay, but the successive pregnancies will produce more seriously affected infants who can die even in utero. Anti-D vaccine, and these proteins keep the immune system from making permanent antibodies to Rh positive blood. So this contains, for sensitization to the mother, very small amount of Rh positive proteins, and the immune system sees them. It thinks it is part of normal routine in life, and antibodies are not made. So this is all about today's lecture. We'll continue later.